Welcome everyone to Nitrous Oxide Analgesia. We have Roger Chute on the phone with us. We're going to begin in just a few seconds. Just want to give everybody that's logging on now a chance to get all fully logged in. We've got a lot of participants coming online right now, so just bear with us for another minute and then we'll be up and running. I did send out a question in the question and chat window. Just want to make sure everybody is aware that you can actively ask questions as we're going through the presentation, and we encourage you to do so. All right, let's go ahead and get started. Again, my name is Lisa Howard. I'm with CAREstream America. I would like to thank everyone for attending our Nitrous Oxide Analgesia Nitrous 101 webinar. We are recording this so that we will be able to go back and revisit it. You can also then share the web recording with others who weren't able to make it to the call. On the phone with me and on the computer is Roger Chute. Roger is a RRT based up in Canada. And Roger, with that, let's kick it off.
Thank you very much, Lisa. As Lisa said, I'm a respiratory therapist, and I've been working for the last few years, very involved in the nitrous oxide side of things as far as product development and clinical application. So I'm very happy to be here, and let's get started. Over that in the slideshow. Oh, start from back. Sorry. Oh, all right. Get the technical glitches out of the way. Look at that. Okay. Sorry about that. There we go. Okay, so nitrous oxide analgesia, a practical guide. Get the formalities out of the way. I do work with CAREstream America very closely. My role is as a product manager and clinical specialist for CAREstream Medical International, which is a sister company of CAREstream America, who are hosting this event. This talk is intended to be an overview, a bit of a practical guide, and I will target it at the labor and delivery setting and its use of nitrous oxide. Because it is intended to be a general overview, I won't be able to hit on all of the minutiae that are related to nitrous oxide use, but I will certainly encompass all of the broader strokes about the gas itself, what you can expect as you implement it in your facility, and some of the equipment that you'll be seeing. So here's the list of what I'm going to talk about. I'll touch very briefly on the history of nitrous oxide. I'll talk some on the gases themselves and the contraindications and side effects, as well as the benefits that it provides to your patients. Safety is obviously a prime consideration with everything that we do with nitrous oxide, and so I'll be talking about that as well, and a little bit about the differences between the type of system that you would see in a hospital setting as compared to in a dental facility, and then some patient instruction information, as well as some information on handling nitrous oxide cylinders, because it differs from what you may be used to at your facility. So nitrous oxide has been around for a long time. It was discovered in the late 1700s and was recognized as providing pain relief by the mid-1800s. By the end of that century, it was accepted by both the American Medical and Dental Associations as an analgesia. It did see considerable use in the U.S., although with the advent of the epidural, the use of nitrous oxide as an analgesic in the U.S. Dropped off quite a bit. In other parts of the world, we didn't see that. So in Canada, where I am, it still is very much the just an accepted part of labor and delivery. And in the UK, of course, they're sort of the anchor point for nitrous oxide use. In England, Scotland, and Ireland, they all report between 70 and 80% of laboring mothers use nitrous oxide. In Canada, our numbers are a little bit less than that, as we are influenced both by Europe and by our neighbors to the south, and other European countries like France and into the United Arab Emirates, areas like that. So there are pockets of use around the world that have been maintained. In the U.S., it's really just seeing a resurgence. In Canada, just as an example of how accepted it is here as a therapy, over 3/4 of our hospitals that deal with deliveries have the option available, and those sites find that they use it in about 25% of the births, and that varies a lot from institution to institution, as well as from region to region. So I'm going to talk about the characteristics of nitrous oxide, and an important distinction here is that for most of my talk, I will refer to nitrous oxide as that combination of oxygen and the gas nitrous oxide, the specific molecule. For this part, I just want to separate that out again and talk about the two individual gases that get mixed. And so when you're working with them in the hospital, oxygen, of course, is a clear, colorless, and odorless gas. Nitrous oxide is very similar in that it's clear and colorless. It has what in the literature is referred to as a slightly sweet smell. I think that's being generous. It does have a little bit of a you notice that it's there. I'm not sure how to define it beyond that. And nitrous oxide is a vapor rather than a gas. Now, the patient, that doesn't really affect things, but as I get into towards the end of this talk, when I'm talking about handling the cylinders, the fact that it's a vapor becomes more important. Both nitrous oxide and oxygen support combustion, and so you would not want to be using it near an open ignition source. So the same precautions that you take when you're using oxygen should also be applied when you're using nitrous oxide. Nitrous oxide, what makes it good as an analgesic? Probably the biggest thing that it brings to the table is the fact that it takes effect so quickly. And it does that because as the patient breathes it in, it moves very quickly from the lungs into the bloodstream, where it's carried to the central nervous system and has its effect. And so you will see somebody, the first time that they're using the nitrous oxide, when they come in, within usually under a minute, they will find that they are feeling the effects. And it may be the pain relief effect, or they may feel a little bit of lightheadedness, but they will know that it's already having an impact on their system. And it moves very quickly in, and it also moves very quickly out of the system, which is the other side of the coin, but it clearly provides some benefits as well. When the pain relief is no longer needed, the mom doesn't have to be under the influence of for instance, a narcotic that just has to be there in her system all of the time. When she stops breathing the nitrous oxide, then the pain relief goes away, and so she gets what she needs when she needs it, and doesn't receive it when she doesn't need it. Nitrous oxide isn't metabolized within the body, or a very, very small percentage of it is. I think 0.004% or something. So essentially what happens is the patient breathes in the nitrous oxide, it has its effect, and the patient breathes it out. That's good because it means that there's no buildup of metabolites or a buildup within the system, within the fat, the things that we see with other types of pain relief where repeated doses may result in over or underestimating the impact of the medication. So that doesn't happen. The cyclic use that occurs with nitrous oxide use in labor and delivery, where the mom's breathing it through the contraction and then she's not breathing it in between contractions, you may find for the first couple that you're developing a balancing point, or things are kind of stabilizing out. So the first time she may not feel that she gets as much pain relief as the next time, and but then after 2 or 3 contractions, you'll find that you reach a steady state, and it remains pretty predictable through the delivery what kind of effect the mom can expect from breathing the nitrous oxide. So the benefits, what are we looking for when we give nitrous oxide? Clearly it's analgesia, that's how it's labeled, and that's how it's what everybody talks about with nitrous oxide. And it does bring that. It is not the elimination of pain, so unlike an epidural that may take the pain right away, the goal with nitrous oxide analgesia is really to take the top edge off, to take the pain and not remove it, but make it tolerable and make it something that the mom can work with and work through. It does have its analgesic effects through activating internal pain moderators, so through the opioid, I spelled that wrong, mechanisms within the body. Anxiolysis is also an important contribution that nitrous oxide makes, and often this is the thing that has, I think, the most impact initially when people start to use the nitrous oxide. You can take somebody who's very anxious and unable to sort of gather themselves, and once they start breathing the nitrous oxide, they can calm down, they can be more cooperative with you and communicative, and really sort of collect themselves to the point where they can get through whatever the next procedure is. The anxiolysis is a big benefit when doing things like IV starts in people who are very anxious about needles. And the third components, we've got analgesia, anxiolysis, and dissociation. Some of the studies that look at having mom rate the pain that she's feeling find that during the use of nitrous oxide that the pain score that is being given is not appreciably different from before mom had the nitrous oxide available. But what they notice and what is being felt by the mom is that they know the pain is there, but they don't care. And this one study showed, even though there was no real difference in the pain score by the moms, that a large majority of the moms wanted to carry on using the nitrous oxide once the little back and forth was over. And so even though it wasn't affecting things on a statistical level, clearly they were seeing some benefit from using the nitrous oxide. So the benefits that nitrous oxide brings, we're applying it directly to the delivery process, but do keep in mind, and I hear this a lot when I go into hospitals, that they see the benefits extending out beyond into sort of the periphery activities around the delivery. So whether it's an IV placement, certainly in the third stage of labor where you've got the placental delivery, any repairs that need to be taking place, it is nice to be able to have a pain relief method that is effective and short-term, so that the mom is not having to be, if it's on an outpatient basis, for something like an examination, then there isn't a prolonged requirement for observation after receiving nitrous oxide pain relief. Another nice thing about nitrous oxide, and this is specifically as compared to an epidural, is that while the mom is receiving the pain relief, she can also take advantage of some of these other practices that may help her get through the pain that she's feeling or the discomfort. Things like being able to pace, using a birthing ball, using the jet tub. Now, some hospitals have, or hospitals certainly have varying policies and procedures regarding what can be done while the patient is using nitrous oxide, but what I have found is that hospitals often start off cautious, as is appropriate, and then when they develop that comfort level, they're able to implement a wider range of pain reduction practices in combination with nitrous oxide. Certainly when you're doing that with every patient, because patients all respond differently to nitrous oxide, you need to start with the patient in the bed, get them through a couple of contractions with the nitrous oxide, then maybe have them sitting up and doing it in a progressive manner so that you're not letting them try nitrous oxide while they're balancing on the birthing ball. Mom remains alert and interactive through the whole procedure. It doesn't make her unconscious. There's again that range of responses. Some moms may feel quite dizzy or lightheaded. Certainly we've had moms, burst out giggling. That's why it's known as laughing gas, because it does provide a sense of euphoria to the patient. And another nice aspect of nitrous oxide is that it's something that we can actually hand to mom in a situation where a lot of decisions are being made around her. We can give her the mask, and we can, after some coaching, we can tell her, look, this is for you. When you need pain relief, you breathe on the mask, and when you don't need pain relief, you don't breathe on the mask. And so it gives back just a little bit of a tiny corner of control in what can be a very chaotic experience. Tolerance. In the literature, there is report of tolerance buildup even within sort of one event of breathing nitrous oxide. So really what that means is you may see a dip in the effectiveness of nitrous oxide. Really hard to judge how much impact that has with labor, because labor is progressive, and so if mom gets to the point where she is no longer able to tolerate the pain using nitrous oxide as her sole analgesic, it may be because there's some element of tolerance, but it may also be just because of the progression of labor to a more intense level. And dependency. Nitrous oxide has a very low, it's a low dependency risk, in that it doesn't develop physical dependence. People don't go into withdrawals. When people are habitual nitrous oxide abusers in the community, then there can be a psychological affinity for it. They like that sense of euphoria, but there isn't that physical dependence that develops with nitrous oxide. So nitrous oxide, as I said, it's not intended to eliminate the pain, and it's not intended to eliminate the epidural. Really, it is something else that you can offer your patients, and it does have some benefits that take it outside of the other options that are available. But what a lot of patients will find is that using nitrous oxide will get them further into the delivery, further through. One of the pieces of feedback that I received from an early customer of the Pro-Nox was that the chief of anesthesia told me he's never put epidurals in so many women that were 9 centimeters dilated. And so in that range of responses to nitrous oxide, there will be those that get right through the process and right through any repairs that have to happen, and they never have to receive any other type of pain relief. But there are a lot of women also who will allow them to get through that dilation phase, and maybe they still will need an epidural at the end, but it gives them all of those other options, the jet tub, the birthing ball, the pacing, and allows them to experience more of the delivery itself. They can still feel the contractions. They can still feel themselves pushing, and so it connects them a lot more with the delivery process than completely eliminating those sensations.
Hey Roger, now's a good time. Let me launch a poll to everybody since we're talking about the epidurals. I just sent out a poll to everybody, so your screen should switch, and the question is, how high is your hospital's epidural rate? So if everybody could select an answer. I see a lot of people selecting. Thank you, thank you, thank you. We'll give it a minute, let everybody get selected up here. It's always interesting to see how high some of the epidural rates are, and I'm always surprised when I'm at conferences when people tell me they're well over 90. And we have 76% of our group has voted. So let's go ahead and end the poll. And the results, your screen should come back, Roger. And the results, just so that everybody knows, we've got 10% of the people on the call have over 90% epidurals. 45% on the call have between 75 and 90%. 20% are reporting between 51 and 75, and another 20% are 26 to 50, and then less than 5% are coming up with less than 25%. So it's very telling that in the U.S., epidurals have become very much in favor. So I thought that was a good time to have the poll. Thank you, everyone, for voting. Roger, back to you.
Thank you. So a lot of benefits with nitrous oxide. There are some things that you need to be aware of when deciding whether or not your patient is appropriate for nitrous oxide. And so I'm just going to run very quickly through the list of the major contraindications that you may come across. And nitrous oxide, as I mentioned before, moves very quickly through the body. That provides the benefit, a lot of the reason that it's something that we're looking at for analgesia. But it also means that if there is an abnormal encapsulated pocket of air in the body, then the nitrous oxide will also gravitate towards that and can expand that bubble. And so in things like a pneumothorax, somebody who has had recent eye surgery where they've injected gas into the eye, they do that to treat retinal detachment. Those air bubbles, you don't want the pressure in them increasing because it can become harmful, and so you need to use that as part of your screening process. Recent ear surgeries as well, if there's swelling and an inability to for the pressures to equilibrate within the ear, then giving nitrous oxide may be something that you want to avoid. Because we're giving 50% oxygen and 50% nitrous oxide, you don't want to be giving it to somebody who needs more than 50% oxygen. And I don't think that will be very many people in the labor and delivery setting, and if they do require more than 50%, they're probably not a candidate for the Pro-Nox for other reasons. They're just obviously very sick. Vitamin B12 deficiency is the most commonly referred to side effect or contraindication to the use of nitrous oxide. Nitrous oxide inhalation can result in an inhibition of an interference in the formation of vitamin B12. And so people who have an already chronic or an already low level of vitamin B12, you'll want to make sure, if they're at risk, you want to make sure that you're not going to be exacerbating that. And so the severely malnourished gastric bypass patients are kind of the ones that keep coming up when I'm talking with hospital sites. Generally, those patients are monitored, and so what I have found is that if hospitals have a monitored level and it's within normal levels, sometimes there's a qualifier there that they're with or without supplementation, then they will use that to sort out who in that group can and can't use nitrous oxide as an analgesic. And then there are also chronic and genetic conditions that can interfere with vitamin B12 availability, and so if a patient has something like that, then you need to be aware and following closely and making a decision based on their individual clinical presentation.
Roger, on the B12, we have our first question that came in. Thank you, Carol Bussman, for sending that in. She has down her question is there is a discussion at our organization around universal B12 screening for women who want to use nitrous. Is that something that can be done that you're aware of?
I'm not incredibly familiar or have a lot of knowledge about what the test is. My understanding is that it's a fairly simple test for a lab to perform. And so my response to that would be, I have no idea whether your facility can do it, but my understanding is just that it isn't a difficult process. It's not something that needs to be sent away to 3 sites in North America or something. So it should be something that can be done at a hospital, like within the facility.
Okay, and we have one other. There's a part B to Carol's question.
Sure.
Carol then asked the question about a subset of women who have the MTHFR factor, and yeah, should they be excluded from nitrous oxide? And then she said, thank you.
Well, thank you. So the MTHFR is a genetic condition where now, and this is a little bit above sort of my, I'm not intimately familiar with all of the components of this condition, but one of it is that they have a chronically low ability to create vitamin B12. And so they would certainly be on a watch list or an at risk, and I can't honestly tell you or guide you whether or not they should be in a separate subcategory that is absolutely contraindicated, or whether they are somebody who also, if you're giving supplementation and monitoring the levels, whether they could also be sort of allowed to use it with a little asterisk, the same as somebody who's had a gastric bypass. So unfortunately, I will answer that question by not really answering.
Well, and Roger, there's one thing. Thank you, Julie Nicholas, for providing me with this. And when the question came in, I did ask her to pull up a couple things for us. And there is an article that we pulled up that was talking about the MTHFR factor. And in it, there is a doctor that's talking about the several different cases, and he is saying in here that I don't think these results should cause panic among the general public, Dr. Irby from the University of Buffalo noted. And they were talking about when it comes to these type of patients, normally you know ahead of time that there were some clues that there might be a problem. And again, you should just understand what supplements, what Roger was saying, and how to monitor them, and maybe they're not a candidate for nitrous. So I don't think there's a whole lot of information out there on it. We'll continue to see if we can pull up some other information and provide it to everybody that's on the call.
Perfect. So nitrous oxide, I talked about the contraindications. There's also some side effects that you will get feedback from your patients, and the most common is nausea. Nausea is sort of a difficult thing to sort out with your patients, whether or not it's due to contractions and the pain that results from them, or whether it's due to the nitrous oxide itself. But there does seem to be a correlation between people that are using nitrous oxide and the sensation of nausea. It can obviously, nausea can progress to vomiting. One nice thing about nitrous oxide is that it doesn't take away the airway reflexes. So unlike somebody who is anesthetized and vomits, your patients will still be protecting their airways. The nausea is one of those things that again, from feedback from clinical sites, that if you encourage the patient to persevere for a couple of contractions, that oftentimes that will go away. And then they'll be able to carry on using the nitrous oxide without that nauseous feeling. So it's worth persevering a little bit, but it is something that is noted in the literature as being a side effect. Dizziness, lightheadedness, drowsiness, and unconsciousness, they're all within that level or degree of response to nitrous oxide. Unconsciousness really isn't, it's mentioned anecdotally. Statistically, it's a minute percentage of the population that will get themselves to the point of unconsciousness. Generally, the literature that mentions it as a side effect, we're looking at nitrous oxide use in combination with another drug. And so if somebody is hyperventilating and breathing very deeply on the nitrous oxide, it is possible that they will get dizzy to the point that their head will fall back. But there are safety mechanisms built into the equipment that we use that will keep the patient from getting themselves into a situation that is dangerous. One of the hallmarks of the safety of nitrous oxide, the way the machines that are used in the hospital are set up, is that the patient can only get the gas if they make a nice seal with the mask, or if you're using a mouthpiece, they have to have a nice seal with their lips around the mouthpiece and breathing in from the system. So if somebody is getting particularly drowsy and they're not able to hold that mask in place, they will stop getting the gas. And then because nitrous oxide clears so quickly, they will, if they've been very drowsy, their eyes will reopen and they'll be able to move forward, and they can modify the way that they're using the nitrous oxide. You don't have to, controlling that hyperventilation reflex that they've got, or maybe understanding that once the pain is passed, you come off the mask or you remove the mask so that you're not getting the pain relief when you don't need it. Things like that, it can be adjusted. The quick clearance occurs also with the side effects. So if the nausea that the patient is feeling, you persevered through a couple of contractions, but they still find that breathing nitrous oxide is just making them incredibly nauseous. The nice thing is that the side effects go away just as quickly as the benefits of the nitrous oxide. So if it's clearly something they don't want to carry on with, within a minute or two, whatever sensation they were having will be relieved. And as I mentioned, their airway reflexes are maintained through the entire process. But we are not just treating the mom, right? When we're dealing with labor and delivery, of course we're treating two patients or sometimes more. And so what does nitrous oxide being breathed by the mom prior to delivery do to the baby? Well, I'll tell you that nitrous oxide does cross the placental membrane, and it is reported as being present in the fetal circulation at levels of about 80% of that you'll find in the mother. But any studies that have been done, most of them have focused on APGAR scores or acid base of the cord gases, and they have found no impact in mothers that have used nitrous oxide as a sole analgesic. So there's one report where the baby's blood gases were a little bit more acidotic, but it was with a combination therapy. So no effect on APGAR scores, no increased need for resuscitation, and there aren't very many studies that have looked at neurobehavioral markers, but those that have found there's no difference between babies of mothers that have used nitrous oxide and babies of mothers that have used no pain relief or epidurals. And so you get what really is a healthy baby whose presentation is not impacted by the mother's use of nitrous oxide. And that nitrous oxide that's in the baby's system will quickly go away within the first couple of minutes of extrauterine life. So we've talked about mom and we've talked about baby, and I recognize that time is moving on, so I'll keep flying by here. The third group of people that we're really wanting to make sure are safe and benefiting from the use of nitrous oxide is you, the caregiver. And to that end, the U.S. has adopted the most stringent requirements in the world as far as maintaining acceptable levels for nitrous oxide environmental exposure for the caregiver. So over an 8-hour shift, the guidelines from NIOSH state that you shouldn't be exposed to more than 25 parts per million. This is minuscule when you compare it to the mom, who obviously she's the one that we're intending to deliver the gas to, but she's getting 500,000 parts per million when she breathes in from the Pro-Nox. And so 25 parts per million is a very small amount. and it's actually a quarter of what they allow or what they consider an acceptable level in the European countries. And so you've got already a safe standard in Europe. They've taken it that much further in order to ensure that caregivers are being protected to the maximum degree. And why are we doing that? Well, there have been studies out that have shown some effects of chronic nitrous oxide exposure from a caregiver standpoint. Most of those studies were done on dental hygienists who are working very close to the patient's mouth, and they were done prior to scavenging being an integral part of the delivery of the gas. And so you get exposure levels 1,000 parts per million, 2,000 parts per million, way above what is acceptable. And over an extended period of time, what they've found is that the dental hygienists that work in that environment were having more difficulty conceiving. And there have also been some other animal studies that have looked at effects on the fetus during the first trimester. And while those haven't been carried over, and you always want to be cautious about interpreting what happens with mice with what happens with humans, clearly erring on the side of caution is the way to go, and that's what the U.S. has done with their regulations and guidelines. And so the other important part of what NIOSH's statement is that using a scavenger is important, and it can reduce your exposure by a significant level.
Can we stay on that for 1 second, Roger? We got a couple other questions that have come in.
Sure.
You guys are doing great with the questions. Thank you very much. We're going to jump to Melinda Warren's question first. Brielle, I'll come back to you in just a minute. Melinda's question is, how often do you recommend testing the air quality with the nitrous oxide monitor badges? We here in the U.S. Have recommended that you take an initial reading with the badges and then at least every 6 months. There are some hospitals that are actually doing it quarterly, so it's something that you're going to find anywhere from quarterly to every 6 months in most people's policies that I've read. That's a good question, Melinda. Thank you. And then Brielle had a question back on the vitamin B12, Roger. It came in, and then I couldn't get you to stop. So I didn't want to interrupt you right in the middle of that. So her question was, our anesthesiologists are asking us to universally screen everyone for vitamin B12 deficiency. And she's asking, is there something that we can provide her to help argue that point?
I don't know of any statistics about sort of percentage of the population that are at risk for having a low vitamin B12. And I'm not sure that
I pulled it. When the question came up, I asked Julie to pull it up, and I was actually surprised that it's a little higher than what I thought. This is just coming off the internet, off of a Google search, and this is dating back to 2000. It's showing that the percentage is close to 40% of the U.S. population is deficient in vitamin B12. And that's a study that's according to Tufts University of Boston. We didn't have a chance to pull up the study or really look at it. So there is a good part of the population that could have a problem with vitamin B12, and some of them may not know about it.
Yeah, interesting. I know that most facilities will take people that they know are at risk or are presumed to be at risk because of their presentation and may screen those. I don't know of anybody that does a general screening for vitamin B12, but it sounds like maybe there is some justification for that.
Yeah.
Thank you.
And then we just had one more question come in.
Sure.
The next question came from Tricia Gordon. Thank you, Tricia. Does each labor room require a smoke evacuation system in order to use nitrous? That would be based on your individual code for your city, your state, your county. And it depends on which NAFTA code they're on. Technically, no, because nitrous is not an anesthesia. So you'd have to give me a little bit more information about what they're looking at. But to my knowledge, there's no universal yes to that question. It's based on your individual state, city, and county jurisdictions. But the one thing to remember, nitrous at the 50-50 mix is an analgesic, not an anesthesia. So Roger, do you have anything else on that one?
No, I think that room ventilation is an important component of maintaining a safe level, but really there are some areas that have regulations according to what is required from a physical standpoint of the makeup of the room. Really, what it comes down to, though, and what it should come down to, is given what you've got, are you maintaining your levels at a safe point? And that comes down to badges. Now, I'm not saying that there aren't regulations out there that require you to have specific pieces of equipment, but really the goal of all of those regulations is to keep things at a safe level. And regulations, unfortunately, are very, as you said, Lisa, and it makes it very hard to keep up with what everybody wants.
Yeah, absolutely. Okay, sorry about that. Go ahead. We're up to date with the questions again. Thank you, guys. This is great that the questions are coming in.
Okay, so talking about environmental exposure, that's a nice segue into just sort of the list of things that can impact how much exposure there is to environmental nitrous oxide. And so it's using a scavenger. The scavenger is the piece of the equipment that takes what mom is breathing out into the mask and takes it away so that it's not just sort of floating out in the room. The room ventilation, how many times does the ventilation system of the hospital refresh the room air with fresh gas? Patient coaching is a vitally important component in that you need to encourage the mom not just to breathe from the mask, but to breathe back into the mask as well. When she breathes in from the mask, that's for her. That gives her the pain relief. When she breathes out into the mask, that's for you, and minimizing environmental exposure. And then using the demand valve type delivery system is also important in maintaining low environmental levels. So when I talk about a demand valve, I'm just going to show you the two different methods that are out there for delivering nitrous oxide. The first is continuous flow. This is what you're going to see in your surgeries or your dental centers, and in some doctors' offices as well. And what it is basically flow meters that provide a constant flow, and then the patient breathes through a nasal mask. Now, the patient in these scenarios can't hold a mask over their face, of course, because there's a dentist in there. And so there's a constant flow going past their nose, and they breathe in through their nose, and they take from that flow, and then they breathe out into that flow. And so what you can see here is the constant flow that's being produced, and then as the patient breathes in, they just take from that flow. Now, there's a couple of things about this, and one is that if the flow is not set right and the patient breathes faster than the flow you're giving, you're going to decrease the percentages that are delivered. And overall, it's effective for dental, but if you think of the labor and delivery setting where mom is taking the mask off and now she's just holding it in her hand for 4 minutes, you've still got that flow going through, and so there's greater potential for nitrous oxide to get into the air. So that's why we don't use this system usually in the hospitals. This is the system that you'll see in the hospitals. It is a demand system, meaning that the machine produces a flow when the patient breathes in. When the patient stops breathing in and is breathing out, there's no more gas being expelled or being delivered into the environment by the machine. So I'll show that to you one more time. So the machine delivers the gas when the patient sucks in or breathes in, and then it stops when they're not. So you get conservation of the gases, but you also get minimal wastage and exposure. When you're coming up to the patient, with the nitrous oxide, most sites will have done their education prior to the actual time of the delivery. I think it's important that you let the patient hold the circuit and the mask and mouthpiece, not just when they're receiving the gas or when they're breathing the gas. Absolutely, it's a must that they hold it. That's part of that safety component that I was talking about earlier. But even beforehand, get them familiar with it. Let them take a few breaths on the Pro-Nox so that they can, or whatever system you're using, so that they can understand how it will feel to breathe through the mask. And getting them to start the inhalation of the gas of the nitrous oxide mixture before they actually need the pain relief. So if the mom starts to feel like contraction is coming, then that would be the time to start breathing so that you build up the analgesic and the dissociative and the anxiolytic qualities before they're really needed, and then they will be able to maximally protect the patient from those sensations. If you start breathing on the Pro-Nox when the pain is at its peak, you're going to be chasing, and you're not going to be providing all of the relief that you could for your patient. And again, there's that message of persevere if there's dizziness or nausea. You may find that getting through a couple of contractions allows better timing of the pain relief by the patient, and they may find that they can then the nausea goes away and they can continue to use the nitrous oxide. And again, always talking to the patient about keep the mask on, breathe in from the mask, breathe out into the mask, and that will be an important part of any patient education. So I want to talk a little bit, very briefly, about the cylinders and how they vary and why it's important. So I talked earlier about the fact that nitrous oxide is a vapor, and contrasting that to the oxygen, which is a gas. So as you can see, an oxygen cylinder is just full of gas. So you cram all the gas in there, it stays as a gas, and as you use up the cylinder, the pressure that's within the tank goes down. And so you can look at your regulator gauge and say, okay, 2200 is full. When it's at 1100, I'm half full. It's very easy to make that calculation. What I want to do, and there's 600 liters of gas in an oxygen cylinder, an E-cylinder. I want to contrast that with the nitrous oxide. So with nitrous oxide, what you see is 750 psi when it's full, but it's not full of gas. What happens with nitrous oxide as a vapor, as you cram it in, it turns into a liquid. And so you've got actually a liquid level and a gas above it. And as the patient breathes the gas, the level of the liquid goes down, but the pressure of the gas within the cylinder stays the same. And so you'll be using a nitrous oxide cylinder for a few patients, and it'll still be 750, but that's not because something's wrong. That's because they're slowly lowering that liquid level rather than affecting the gas pressure inside the cylinder. When the liquid is all gone, then the cylinder will, the pressure will decrease the same as when an oxygen cylinder is at 750 at the same rate. So the other thing to note is that liquid level in a nitrous oxide cylinder means that unlike oxygen, where it's pure gas and you can have it upside down and run it, and you can lay it on the bed and run it, with nitrous oxide, whenever the cylinder is being used, it always needs to be upright or near upright. And that's to avoid, if you imagine this cylinder, the blue cylinder on your screen being turned sideways, the liquid will flow towards the valve, and then it'll be liquid instead of gas that comes out. This will probably damage your equipment, but also when the nitrous oxide liquid is exposed to the environment, it evaporates very quickly. And when it does that, it gets very cold and can cause frostbite. So just something to be aware. Nitrous oxide should always be upright when it's being used. So just a quick wrap up here in talking about the nitrous oxide and the wave that I see building in the US. It's very exciting that only 5 years ago there were probably 5 or fewer hospitals that were offering nitrous oxide in labor and delivery. And now I know that there are at least 50 sites, and that rate of growth is exponential. And so there's a lot of excitement, a lot of activity, a lot of people adopting it, and we have seen very organic growth with the sites that have adopted the Pro-Nox, in that the sites around them will then also be looking at nitrous oxide. And some of that is from a competitive standpoint. You know, you can advertise that you're using that you have nitrous oxide available, but it's also, I have been amazed at the community of support that is out there in the labor and delivery community. That that there's so much openness and willingness to share experiences and forms that people have made up in order to facilitate somebody else being able to offer this to their moms, and I think that's awesome. There are a lot of hospitals out there. It's also interesting to note that it's not one sub-segment that is adopting nitrous oxide. We've got very large referral centers that are doing 7,000 births a year that are adopting nitrous oxide. We've got small community hospitals that are adopting nitrous oxide, and they all have their little reasons. Primarily, it's to be able to offer something to mom to facilitate a closer to natural birthing experience. But the community hospitals love it because the anesthetist that has to come in from home, now they can offer a pain relief to the mom while she's waiting for the epidural. For the larger centers, it's about being able to offer the latest and something that is very much in the public's mind, and birthing centers also are offering nitrous oxide, and it's a huge benefit to them if they can provide some pain relief and not have to transport their patients to their referral site. So there are a lot of benefits, a lot of different reasons, and a lot of the same reasons why so many people are looking at nitrous oxide, and it's very interesting to watch and fun to be a part of. So analgesia, anxiolysis, and dissociation, those are the things we like about it. It's safe for mom and baby, and it's certainly safe for the caregiver as well, and it gives mom a little bit of control. I think those are the things that I love about nitrous oxide, and the things that I like to talk about when I'm at hospitals discussing the equipment that we make and that we sell. So thank you very much.
Roger, we've got another question that's come in. This question came in from Dale Baker, and thank you, Dale. Are there any processes that we can implement that can prevent staff diversion of nitrous?
Yeah, that's something that I hear a lot about when I'm at the individual hospitals, and there are a variety of different approaches to that. Some hospitals take the nitrous oxide regulators and lock them up. That's a bit of a cumbersome approach. It is effective, but you don't like to have to assemble equipment when you need it. A hospital that I was just at about 6 weeks ago keeps all of their nitrous oxide or their Pro-Nox machines in a little, it's sort of a back area, but it's right in the nursing station, so keeping them exposed and basically minimizing the opportunity for abuse of convenience, essentially. And I know other hospitals lock the equipment up in the med room, for instance. So there are a variety of things that can be done. There isn't one sort of solution for all, but certainly it's something that is top of mind when people are adopting nitrous oxide, that you don't want it to be a temptation for your staff to be helping themselves.
Okay, great. Thanks, Roger, for that, and I answered that as well online for everybody. I also just launched one last poll. Have you started on your nitrous policies and procedures yet? It's a yes or no question. And everybody is voting. Thank you, thank you, thank you. It looks like we're done, and it's almost split 50-50. We've got 56% have said no, and 44% have said yes. So with that, what we're going to do is, again, this presentation that Roger gave has been recorded. Over the next few days, we'll get all the recording and everything ready, and we'll get it posted, and I'll send you out a web link to that. And also, we have many hospitals, as Roger talked about, that share their policies and procedures. So let us know where you're at with your nitrous journey, and we'd be happy to help you. And I thank everybody for your time. And Roger, thank you very much for your time. Very nice information. Great job. And hopefully everyone found it useful.
Thank you very much.
With that, we're going to close the call and look for an email after the conference call. And if you would, take the short survey. That'll help us make the next webinar even better. Thank you so much and have a great day.